we're going to do some scenario-based pain management today, which is a slightly new idea that we've had that was kind of requested from the training hub as case-based discussion. So we're going to have a go at that, and then we'd really value your feedback afterwards. So I'm Graham Dunthorne. I'm a GP, and I've been working with a specialist interest in chronic pain for around 4 years now. And I do that on a regular basis. I've done the Masters in Pain Management with Cardiff University, and currently I lead a team in Lincolnshire who are trying to raise awareness around pain and pain management, and particularly opioids across the county. And I think Emily's going to give me a little bit of assistance today. Do you want to introduce yourself, Emily? People probably know you anyway.
Probably. So I'm Emily Topham, one of the project managers from the ICB's Medicines Optimization team. Yeah, I'll be monitoring chat and general dog's body, and I think today.
Excellent. Okay, so so working for people with pain, which is what we're doing all the time, and really I think we can all reflect that we're all doing this all the time. And so there's definitely a need out there. So 1 in 5 adults worldwide living with persistent pain, and that may well be a conservative estimate. And certainly within a county like Lincolnshire with lots of long-term health problems, it's a conservative estimate. There's definitely a deficit. Many people unable to access modern progressive pain management. And I think, again, perhaps we can all reflect that there are many patients where we feel that we may not be able to do as much for them as we would like. But this creates a fantastic opportunity to make a valued difference in those people's lives. So our aims and objectives today, primarily we want to consider a safe and a rational approach to prescribing in persistent pain. And to do that, we're going to review 2 common persistent pain conditions and just have a look at the current prescriptions and what might be the rational next steps to take. So we were going to do that in small groups a bit as well, through breakout rooms. I think we may not be able to do that now, but we'll certainly have some open discussion around those prescriptions. And then secondly, we want to consider that medication as part of a wider pain management plan, so which really kind of responds to the person's lived experience of pain and remembers that medication is just one element of a pain management plan. Okay, so firstly, persistent pain, what is it? So I think, from my point of view, I believe quite strongly that to really manage pain well, we have to have a really thorough understanding of what pain is. And we've certainly got a difficulty out there at the moment amongst patients and amongst professionals, that whilst our understanding, I think, of pain has developed quite considerably over the last few decades, that is not necessarily common knowledge out there amongst our colleagues and amongst patients at the moment. So we're going to start today with just this 5-minute video. And the idea in this talk was to embed some of the resources that we use throughout the talk. And this means that you can tap into them afterwards as well. And also you can signpost patients to them. So this is a common video that's out there on YouTube, and it's really great for patients. And we'll just start with that today, just to remind ourselves kind of what we're dealing with. If I can make it work. Okay, so from that, hopefully, you can see that pain medication may be an element of a pain management plan for some patients, but it's very much a part of it, and we need to be considering the whole picture. So this is just to remind really that pain is a lived experience. It's something occurring in an individual and in the context of their life, and it's really helpful to try and explore that. Now, of course, those themes in any one individual can be infinite, really, but I find that just kind of exploring these 5 main areas is really helpful, and often the themes tend to center around these things in most people. So, how do you think? So that kind of refers to our belief system about pain. Does the patient understand pain in the context of the video that we've just watched, or do they have a more unhelpful belief system, which might be a more kind of structural model around degeneration and it's only going to get worse, disability is going to increase, etc. And that can come with a lot of emotional distress and with avoidance type behaviors. How do we feel? So this really just refers to people's mood and their emotions. And of course, we know that when people are not feeling good, their life experience is less good, and their pain tends to be less good within that experience. So how do you move? Really important, how people manage their activity, the activity that they're doing currently, but also, are people using movement therapeutically at all? Movement is good for physical health, it's good for emotional well-being, and it's good for pain. But many people will just kind of store up their movement to use when they have to kind of get something done. It's task orientated movement rather than actually using movement therapeutically. We'll just explore that in a little bit. How do you sleep? Again, really important. If people aren't sleeping, then their life tends to be worse and their pain tends to be worse. And then just more widely, how do you live? And that can incorporate those kind of lifestyle things. It can incorporate people's families. It can incorporate socializing, spirituality, um, um, all those kind of factors. So we'll just try and look at those bits as we go through the cases. So we're going to start then just with probably the most common case that we'll ever see of persistent pain. So it's chronic low back pain or persistent low back pain. And this really accounts, I think, for around about 85, perhaps slightly more percent of patients who are currently referred into the pain service in Lincolnshire. And there is more worldwide disability due to persistent low back pain than any other condition. And this would be a very typical picture. So a 64-year-old gentleman here, 30-year history of pain, no particular traumatic onset, just came on insidiously. And that's going to be the case probably for around half of patients, maybe even slightly more. There will be some patients who will recall a specific initiating event. That might be an accident, a so-called slip disc. It might be a road traffic crash, something like that. But many patients don't recall anything at all. And he reports a gradual increase in the frequency of pain, the severity of pain, and the topography of pain. So basically, the pain is felt over a wider area than it was previously. Generalized lumbar aching. And also with these patients, even though they'll say low back pain, when you explore that a bit, you will find they have pain in other places as well. And typically with back pain, they have pain in other places in the axis, like the neck, and extending out into the buttocks, the hips, the shoulder girdle as well. We see these MRI reports that say multi-level degenerative changes. That's a really out-of-date term that we still use. Implies that everything is getting worse, which is not the case. So these are age-related changes, and they come to all of us, and they don't specifically explain why somebody has pain. And usually we're just checking that there's no overt nerve compromise, that the spinal canal is patent. And from there, the spinal team will usually say no surgical target, and I'm sure we've all seen that written. Just for completion, we'll say that he's had a few injections in the past, and they just provided some modest relief for a few weeks, so we wouldn't be repeating those. And so commonly, patients will say they've had physiotherapy in the past, which exacerbated pain, and it can be really important to explore that, because that may well just be some massage, some manipulation, and a home exercise program. And commonly, people will have done that home exercise program alone, and often they'll say that they gave it a good go and it caused pain, and they may just have started too quickly for them. And we'll see the kind of difference with a more rehabilitative approach in a minute. So that's our patient, and these are kind of normal expectations that the patients have. They want to reduce pain, maintain better activity levels. They believe that current medication is less effective than previously, and they would like to stop ineffective medication and take something better. And just, this patient's picking out a few side effects there as well. He's gained some weight, he's reporting some brain fog, and he's snoring more than previously, which upsets his partner. Okay, so this is where we were going to do a breakout. And as we don't seem to have breakouts working, what we'll do, there's not that many of us. So if we just have a look at the prescription, which is about to come, on the prescription, it will give you the drugs that the patient's taking. And there's also a little bit on there about what the patient is saying about the individual drugs. And then perhaps in the chat, we can just pop in what would be our approach to those different medications. Would we reduce it? Would we increase it? What would we do? And I would encourage to ask yourself 4 questions with pain medication. Is it recommended? And that's referring to our guidelines, and of course NICE are the major ones we use. Is it definitely effective? Do we know that that drug is helping that person's pain? Is it safe? And that kind of refers to your side effects, like the sort of ones that the patient's mentioning: weight gain, brain fog, and snoring. And is it definitely wanted? Does the patient want to take it? And of course, this patient has expressed that it really does not want to take anything which is ineffective. Okay, so we'll pop that prescription up now, and then just use the chat to say what you might kind of do in this scenario. Or questions as well, if you're not sure.
Graham, should we let people also open the mic to have a chat as well? Feel free to
Yeah,
share
if people
your
want
answers in the
to
chat.
speak about it, then
yeah.
that's fine. Yeah.
I'll start then, Graham.
Yeah.
I think
Yeah.
I will start with asking the question that you've just said previously, because I want to look at more holistically how they are getting on, and then what's their expectation for pain.
So what I'll just say, Ewan, is if we just this case, we're going to break down into 2, and then the second case we're going to bring together. So
Okay.
if we just focus on the prescribing for this bit, and then we're going to go into a little bit more in a minute, if that's okay.
Yeah. So should we look at just meds today then, and then go from there?
For this little bit, we're just going to look at this
and
prescription. Yeah, so we're going
one.
to focus on the medication for this slide, which is the prescription in front of us. So, anyone has any particular thoughts about that? Okay, so someone said there. So Rachel said I would start with naproxen. So, any do you fancy popping on your mic a second, Rachel, and we'll just talk about the naproxen?
Hi. So
Hi.
I think that would be the easiest way in to start,
Okay.
because the benefit to the patient is unclear, and we've got the interactions as well with the ramipril, potentially reducing the ramipril's effect, and possibly increase risk with and the omeprazole there, which might be just for the stomach protection, so polypharmacy. So I think that would be the easy start one.
Yeah, that's really good points, and obviously, yeah, the ramipril was just snuck in there as an extra factor. So that's brilliant. And any sort of, how would you kind of tend to go about that? Any thoughts on that?
I think I'd describe those things, saying, well, if we're not sure about that benefit, let's try reducing that, leaving it off, and also putting in the adverse effects to help the patient understand why it's important to look at reducing that and the effect on the kidneys, etc. Just to get them on board, really. Because when you've got so many pain medications, I think you perhaps have to do it slowly and medicine by medicine, rather than, right, we're going to take everything away and frighten the life out of them.
Yeah, no, absolutely. It's a really good point. And if possible, we do sort of tend to go one drug at a time. NSAIDs are a bit of a bugbear of mine, because I think often, because they are recommended in the NICE guidelines, it's one of those ones that just seems to get left on. But the reality of the research is that actually, some patients get mild to modest benefit from an NSAID. And if it's not effective, then obviously there's lots of risk. So yeah, I just tend to say, well, try taking it once a day for a week. If you don't notice any clear benefit, any clear change in your pain, then knock it off and do the same. Absolutely. Fantastic. So a few people saying about look at the gabapentin. Does anyone want to come in and sort of say how they might go about looking at the gabapentin? Well,
reducing it slowly, even if it's no benefit for the patient, stopping it really quickly is gonna bring up some unpleasant side effects, some for the patient. So just making like a plan with the patient, how to reduce it, and start with the morning dose, after this lunch dose, and evening dose. I mean, we need to clarify with the patient if he's indeed taking 600 milligrams 3 times a day.
yeah,
Because sometimes they just take 600 milligrams before going to bed, and for the rest of the day they will take 300 milligrams. So
yeah, absolutely. I think it's a really important drug to address. It's not recommended for back pain or sciatica now, but sometimes, certainly historically, it would be prescribed for sciatica and then just kind of left there. It's dependence forming, so it's very likely the patient will be tolerant to it. And you're absolutely right. Once we know that they are taking it like that, then reduce it slowly. And when they're at 1800 a day or below like that, my personal way is just to reduce by 100 milligrams a week. So a nice slow reduction. If you felt there was some risk in this patient, then you could go faster than that. You could try sort of 300 milligrams every 1 to 2 weeks. And it can be helpful to know whether the patient is already missing doses, because if they're already missing some doses and they're not experiencing withdrawal, then you're safer to go a bit quicker. There was snoring was mentioned in this patient, and so that raises the possibility of obstructive sleep apnea. And we would want to understand whether there was any evidence of breathing problems at night, so nocturnal respiratory depression. So that might manifest in strange breathing at night or breath pauses. And we know that the risk is increased when patients are on combination of drugs, and particularly opioids, gabapentinoids, and benzodiazepines. So that's a bit of a red flag there, being on morphine and gabapentin at the same time, and snoring at night. So yeah, fantastic. Would you start with naproxen? Would you start with gabapentin? There's no specific rule to that. If there was respiratory depression going on, or risk of that, then I would probably be going with the CNS depressants first. But yeah, there's no fixed rule to that. So, I mean, what do people think about the Zomorph? No one, I don't think anyone said in the chat there that they're going to look at that. So let's have a look. I would advise only around 20% of patients have an effect. Yeah. Tapering guidelines. Yes, thank you, Emily. Yeah, so no one's really said anything about Zomorph. What do people think about that? Yeah, no, you're right, Emily. So obviously they're on a quite high dose there. That's the so-called high risk threshold. Yeah, no evidence. Patient thinks it's effective. Do people think it's effective? Maybe not. I mean, this is a really common misconception that patients have, that they base it on the fact that if they miss a dose, they experience pain. And of course, if you miss 50% of your dose, then you're quite likely to withdraw if you're dependent on the drug, and withdrawal is often painful. So it's really useful to explain that to the patient, and explain that the only way to really know whether the Zomorph is effective is to reduce it a little bit and see whether there is a significant change in their pain. So in that patient, I would probably just be taking them from 120 milligrams a day to 110 milligrams a day, and then speaking to them again in a couple of weeks. And hopefully you will kind of prove to them then that, because most of the time they don't report any change or no significant change. And then you can have that conversation which says, you know, look, that does show that it's not effective at that dose, and you can continue to gradually reduce it then. Exactly. So that's yeah. So just highlighting there, Leah, those misconceptions around opioids, and a lot of getting started on opioid reduction is around having those open chats and dealing with some of those misconceptions. So just to finish off that prescription then, I mean, I think the amitriptyline is the one that I would probably be less bothered about at the moment, because it is having some meaningful impact, we think, for his sleep, and ultimately probably the other ones are of greater priority. Paracetamol, if it's not effective, I just tell people not to take it. You know, you either notice an improvement in your pain an hour after you take it, or you don't. And if you don't, there's no point. It's important just to explore anything herbal, cannabis products, recreational drugs. Patients will try all sorts, and we've already mentioned the ramipril. So, you know, in summary, with that prescription, you're absolutely right. One drug at a time if possible, but be aware of those red flags like respiratory depression. Doesn't exactly matter where you start. That's a bit of a judgment call. If there's evidence of CNS depression, I would probably start with those. But naproxen is nice and easy to address, so you know there's nothing wrong with that. And ultimately, this patient's on a lot of medication, which is no longer effective. So before we move on from that, are there any kind of questions left around that prescription that people just wanted to raise that we've kind of not touched on?
When reducing the Zomorph, do you recommend having some Oramorph for, you know, when required?
Not necessarily, no, not to reduce the drug. If I was reducing that, I would probably do 10 milligram reductions at first, and then once, depending on how it goes, often once we're down below 100 milligrams, I kind of drop to 5 milligram increments. So it's just maintaining a lower increment of a kind of around 5 to 10% when you're doing it, and I find that patients tolerate that well. If you get patients who use Oromorph every now and again for sort of severe breakthrough pain, then I'm less bothered about that really, because they're not really using that as a management plan for chronic pain. They're not using it for long-term regular use, which is when we worry about tolerance and dependence with opioids. So yeah, I mean, occasional use of Oromorph, not bothered, but you do have to be careful that patients don't fall into the trap of essentially using it regularly, at which point, you know, it just becomes another regular opioid.
Thanks.
Okay, so I'll go back to that. So we're just going to expand this pain story a little bit, like I said. So that's just to summarize NG59, so which is the low back pain guidelines. There's a long list of things not to consider there. NSAIDs at the lowest effective dose for shortest possible period. We spoke about that. Weak opioids for acute low back pain. So again, you know, if people are using opioids to manage breakthrough pain on a limited basis, then fine. But what we're trying to avoid is long-term regular use, which will promote tolerance and dependence. And then they don't comment on muscle relaxants. So there's things like diazepam. Obviously, I'm sure everyone has seen that, probably used diazepam. The American guidelines do include diazepam or muscle relaxants for acute pain. And again, it's one of these things that if it's safe and they're just using it very sparingly as a rescue therapy, then I don't tend to be too worried about that. Of course, as we know, benzodiazepines are not recommended for regular use. And in this patient, you would be quite cautious because they're already on an opioid, they're already on a gabapentinoid, and they're already experiencing some symptoms which are suggestive of obstructive sleep apnea. Okay, so I'm going to put up, this was for the next breakout room. We'll just discuss again. So I'm going to put up the other elements of the story in a minute again to discuss just a few elements that I've picked out and just thinking about those questions again then. So we're not really going to support this man too much with medication here because he's essentially tried all that and he's not responding to it. So it's, you know, it's useless in terms of a pain management strategy. We just want to taper it off so that it's not having any long-term effects. So you know, the patient wants to know how to be supported. So it's going back to those questions. How do you think? How do you feel? How do you move? How do you sleep? How do you live? So these are just a few elements from his story. So he understands that pain is due to a degenerating spine and arthritis. This is kind of what he's been told or what he remembers of it. The spinal surgeon said nothing can be done, and that stuck in his mind. He expects that will get worse with time, and he just wants to stay active as long as possible. And patients say that, which kind of implies that they think one day they are not going to be able to be active. And this worries him because he worries about being a burden. Again, a really common thing that people say. So interestingly, he's actually pretty comfortable when he's resting. So he's kind of getting more comfort out of rest than he is out of pain medication. And he feels pain after about 15 minutes of activity, at which point he'll complete his task, but he'll tend to sort of collapse with pain and require rest for several hours to get over that. So let's kind of just open up to the chat again, or you know, or people to speak is fine. What do people think about that? You know, can we support people a bit differently with that pain story? I'll let you go first, Ewan, because you said you were going to for this bit.
I think a lot of it is patient's expectation that it will only get worse.
Yeah.
And what that, and then added on to is worrying about the future and the burden to the family. Trying to understand a little bit more of that and manage the expectation more realistically.
Yeah, absolutely. So which sort of those questions that we were talking about are kind of captured in these elements of the story? But you've just talked there about how do you think? I would say, you know, this is the patient's belief system, what they understand of pain. So they're in a very structural model. They believe that their spine is degenerating, which means it will get worse. And often people associate that with a severe risk of disability. And that is obviously scary. And fear tends to promote and retain persistent pain. And it also tends to lead to avoidance behavior. So people don't want to move and things because they're worried they're going to make it worse. You know, Lorimer Moseley, who people have heard of as well, he did a trial where he looked at gabapentin versus just pain education, just explaining to people what persistent pain is, and gabapentin was no more effective than just explaining pain to people. So, you know, if we can kind of reframe pain towards the model that we saw in the video at the start, then it gives people a bit of space actually to think, you know what, I'm okay. My back is fine. I've just got a normal back for a 60-odd-year-old. And actually, maybe people can help me to move forward in ways that I didn't think were possible. Anxiety associated with this, absolutely. Yeah, pacing strategies. So we'll come to that in 2 seconds. Does he have mobility aids transport? Yeah, absolutely. So we can try to, this is about how is your life? Absolutely. This may well just be stopping him from socializing, seeing friends. And if we can support people to do that, then often they will be happier. Their lived experience is different, and therefore, you know, their pain experience is different. So yeah, there's some really important. So how do you move? So here we go. Actually pain much lower at rest. So really so common. He's task orientated like most of us. He gets the pain after 15 minutes, but rather than necessarily listening to that, he forces on through to get his task done. And usually that comes from some deep frustration because, you know, people have always done that. And it's really, really challenging when your life changes and you might have to adapt to something that you don't, you know, really want to adapt to. But it can have a massive impact on patients and a massive impact on their pain if we can change that through, as you say, pacing or chunking activity down. So with this chap, I would be saying to him, well, you know, when you start to feel that pain rise after 15 minutes, can you take a break there? Can you rest for a few minutes, let things calm down, and then go back to your task? And it may be that he completes that task in 3 chunks or 2 or 3 chunks rather than 1 chunk. But the effect of that can be that he can complete the task without that significant rise in his pain. He doesn't collapse with his pain, and he doesn't require several hours of rest to get over that. So he actually then just gets on with his day. Hopefully he can do a bit more. And when people manage activity better, they often find that over time they can manage to do a little bit more and a little bit more and a little bit more. But when people manage activity poorly, when they push through, they're completely task orientated, then if you ask them to look back over the last 5 years, I guarantee they'll say to you that in reality they're doing a little bit less and a little bit less and a little bit less. And it is really, really hard to get people to change, and it will often take several consultations, but it can be done, and it can make a difference. Any questions about that? In these next slides, there are some embedded resources. So just to live well with pain. So movement and activity there, people can be referred to. And there's some more pain education. So there's the video that we watched at the beginning, and there's this video as well from Lorimer Mosley, which is also brilliant. So if you've not seen that, we won't watch it now because there's not the time, but if you haven't seen that, I would encourage you to watch it, and also to refer patients to it. And Emily is just popping in the chat there about extra training we are providing. So thank you, Emily. And what we're also starting soon, I'll just plug this now actually. So we're starting something called Empowered Relief soon. That's going to start in June. And basically Empowered Relief, it was developed 10 years ago at Stanford University, and it is a 2-hour primarily didactic session. And it kind of aims to rapidly equip people with pain education and with some basic self-management strategies. And it's really about access for patients, trying to get this kind of basic advice to as many people as possible. And if you see a patient and you're picking these things out of their story, but you don't necessarily have the time to go through a lot of this stuff with them, then by all means, in due course, we'll provide the link to everybody, and you can refer patients to that Empowered Relief session. And that just gives them that kind of foundation, that grounding. And we'll also be signposting within that session to other resources that are going to be available in links. Okay, so pushing time a little bit now, but this is just the second case. And the idea is we're going to kind of bring those elements together a little bit this time. So fibromyalgia syndrome, now again, obviously a really common condition that we see and is referred into the pain service and managed within primary care on a regular basis too. So this is your kind of very typical textbook picture. Just going to close down my chat because I can't barely read my slides. So 20 years of widespread pain with no clear initiating event, ultimately referred to rheumatology a few years back and diagnosed. So axial pain being the low back, the neck, and then 4-quadrant pain and widespread body tenderness. IBS and chronic migraine too, and then this kind of common intrusive physical, cognitive, and emotional fatigue, persistent stress, depression, and anxiety, and very commonly difficult experiences with healthcare providers in the past will have put many patients off, and you will have a back catalogue of to kind of get through and make sense of. So this breakout room, we were just going to consider the whole thing this time. So the medication and the whole story in one go. So we'll put that up now. Okay, so just again, picked out a few elements. So feeling overwhelmed by the current situation, feels unable to keep up with children and be a good mum, as she says. I hear that so often. Constantly stressed, taking her 1 to 2 hours to initiate sleep and waking several times due to pain. Taking sertraline 100 milligrams, which is not helping for pain or for mood. Previously was on fluoxetine and citalopram. Also on pregabalin, been on that quite a while, initiated by rheumatology and gradually increased. And she believes she would be worse without that drug. Okay, so what do we think about this? Either the story, the meds, whatever people want to comment on. I'm going to put my chat. I need to open that chat again. Oh, Emily's put the Empowered Relief link up. That's fantastic. See, I knew it was a good idea you coming, Emily. For some reason, somebody's commented below, but I can't seem to get it to go down. So yeah, so absolutely. So there's clearly, you know, how's she living? It's not quite working. She's struggling with the family, and I totally agree. I mean, social prescribing input would be great here. A lot of the time, patients don't even know that that support's available. Emily, can you read? Oh, I've got it to go down actually. So I'm thinking about amitriptyline would help with her IBS and depression as well instead of sertraline. Okay, yeah, so I think that's a very reasonable point. So she may well want to review her antidepressant. She's had SSRIs there, hasn't she? And absolutely converting to either an SNRI like duloxetine, or like you say, in the context of IBS, amitriptyline may be able to have a meaningful effect on various things here, and may also help a little bit with that initiation of sleep. So you're going to kind of be in the realms of a careful cross taper between sertraline and amitriptyline. I don't know if people are aware of this, but there is a new Cochrane review out very recently about antidepressants in chronic pain. And that has basically said what we all knew anyway, which was that there's absolutely diddly squat evidence for most of them. And the vast majority of evidence, vast majority of trials have been done with duloxetine. Our use of amitriptyline really just comes from the fact that it's been used a lot over the years, so it's primarily experience, anecdotal based evidence. But scientifically, if you've got some noradrenaline reuptake inhibition, then you should get, you know, theoretically there should be more descending inhibition in the spinal cord than with an SSRI. And that's why we have tended to go for those drugs. So yes, the reality of antidepressants is that mild to moderate benefits in some patients. It's not necessarily going to change her life, but I agree there's kind of a meaningful reason to have a go at that if she's keen to do so. Any thoughts on the pregabalin? Or any thoughts on some of those wider elements of her story as well? Could you read the chat out, Emily? For some reason, my scroller is not working and I can't see.
So the latest one we've got is from Leah saying, I'm thinking about amitriptyline would help with her IBS and depression as well.
I think there's one from Leah that's just come up below that, isn't there? Or is that just being typed? Is that why I can't get it up?
That's being typed.
Maybe that's just being typed. So, okay, so what do we think about when patients say that, which they do quite a lot, I'd be worse without pregabalin?
Maybe trying to see if it's really working for her, or it's just, you know, she's just used to take it because she's afraid to reduce it.
Yeah, and how would you do that?
Having an honest conversation and suggesting that we could see if it's working for you, trying to reduce it slowly. In this way, you are not going to have any withdrawal presentation. You will be able to function better. I mean, probably because she's so stressed, she feels like maybe she's not alert enough during the day. I mean, reducing the pregabalin could help with this as well. She's gonna feel more, you know, alert during the day, keeping up with children and things like this. I mean, we could link this reduction with family life and what she needs to do with, you know, in her family life.
Yeah, well, I mean, yeah, that's everything really, you know, absolutely. So we don't know that it's effective. It's a dependence forming drug. If she's just taking it regularly all the time, it may well not be. Like with the opioids, the only way is to make a small reduction and to see whether there is a change. It may well be impacting on her fatigue, her stress, her coping mechanisms. Really good point from you in there as well. You know, childbearing age and potentially teratogenic. So yeah, absolutely. And that's going to be the case with antidepressants as well. I mean, not specifically teratogenic, but of course, there's a major caution in pregnancy. So absolutely, I would try to educate the patient about a careful reduction in pregabalin to assess that drug. Pregabalin is not recommended in our guidelines for fibromyalgia anymore, which, you know, NG193. You see it a lot. It is in the EULA guidelines, which is why you see rheumatologists using it. The statistics are that about maybe 1 in 10 patients will get a moderate benefit from pregabalin, and maybe about half of patients will get side effects. And of the ones who do get benefits, then many will become tolerant to the drug over time. So the problem with pregabalin is that if you just, you know, take a patient who's not on it and you consider initiating it, you're odds on to do harm. I think that's the problem. It's difficult to find the people that are going to benefit. Okay, then. So just quickly now, then. So the wider story, obviously, there's lots going on there with mood and emotion, and there's lots of ways basic ways we can support people. It may be just signposting into things like Steps to Change, but it also might just be teaching people around relaxation and self-soothing practices, pain acceptance. And again, there's some links to the resources on that there. So do have a read afterwards and use them for your patients. And again, there's loads on that stuff in Empowered Relief. So please do use Empowered Relief. Sleep, the best available evidence for sleep strategies is for CBT for insomnia. Drugs are not considered a long-term, an effective long-term strategy. I mean, by all means, if we get some meaningful effect out of amitriptyline, then fine. But if you're not, you know, it's really important to just explain this to patients, take a sleep history and signpost them to some resources. So that's just to highlight NG193, which you can use to which are the chronic primary pain recommendations, of which fibromyalgia is one of those conditions. So do consider duloxetine, amitriptyline, sertraline, citalopram, fluoxetine, paroxetine. No idea why they put paroxetine in. I mean, barely anyone uses that now, but it is in there. And whether these will stay exactly the same, I don't know. But I think focusing more towards duloxetine, amitriptyline, if we can, makes sense. And basically, do not initiate any other drugs. So, you know, 10 minutes is not very long if you're doing a 10-minute consultation. I passionately believe the most important thing is to listen to the patient. The last patient I saw before doing this talk said, it's just great that someone listens to me. And patient says that so often. And in the end, pain management is a process. And you absolutely don't have to have this specific outcome at the end of every consultation. And if you just listen to people and you're curious about their situation, then you're laying the foundations for future consultations as well. And then, you know, just make suggestions and collaborate with the patient. A lot of pain management is asking patients to change change the way they're going about life. And we know from change science that many people don't change easily. Often it takes time. And if you tell people to change, then they kind of usually won't. So suggest, collaborate, give people the option to come back and have more time. So in summary, pain is a lived experience, and an effective pain management plan has to reflect that. Pain medication may be a meaningful element in some patients, but we should prescribe with care, and we should be safe, and we should be rational. So thank you for listening to our talk today. And obviously, we are at time, but I can take a few more questions if there are any.
Thank you. The Empower Relief session that you have on, so it's similar to a group consultation? Is it because it's a pain class, 2 hours, and then people join in at their own home?
Absolutely, yeah. So it's online. People join from the comfort of their own home. It's primarily didactic. So it's not about bringing people in and working with them and having breakout rooms and things. It's primarily around delivering basic pain education and self-management advice, but in a kind of lecture-based informative way to try and really get that buy-in from patients that what we're saying is right, is based in science. It's not complete sort of mumbo jumbo, if you like, and hopefully, from there also signposting to the various other things going on in Lincolnshire, to referral to the pain service if necessary, so that people can get more support if they need it.
Brilliant. I'll share it with the other clinicians.
Brilliant. Well, if there's no more questions, no further questions, I will say thank you very much and disappear